my name is Adele. I'm an internal medicine resident down in Wilmington, North Carolina. Today I wanted to talk about an interesting location for a vegetation, the setting of strep mitis bacteremia. So infective endocarditis is defined as an inflammation of the endocardium or lining of the cardiac chambers, valves as a result of hematologically spread bacteria. Infective endocarditis is pretty prevalent. It affects about 10 to 20,000 patients each year. 80% is majority caused by staph and strep. Gram-positive may accumulate, causing reactivity of platelets and fibrin clumping, forming these vegetations that you see with the infection. They're more commonly located on the valve leaflets or foreign implantations, and almost unheard of, but not impossible on the Chordae tendineae, as we see in the case today. So we had a 29-year-old female who presented with a pastoral history of uncontrolled type 1 diabetes, complicated by gastroparesis and neuropathy. She also had gastritis and chronic hep C and polysubstance abuse. She had history of the polysubstance abuse and narcotic dependence on Subutex currently. So her use was in remission. And then a history of DVT, not an anticoagulation at the time. So she presented with shortness of breath, abdominal pain, and lower extremity edema. She actually recently returned from a cruise in the Bahamas where symptoms actually arose while she was on the cruise. She was evaluated by the physician on the ship who was concerned she might have some sort of pulmonary edema based off her shortness of breath and physical exam. And they actually instructed her to go to the ED after she returned from her cruise. She had also fevers and chills with the shortness of breath. She had cough, congestion, malaise, nausea, vomiting, so a slew of kind of non-specific symptoms on top of that. And then she also has this non-specific history of abdominal pain. She was following up at Chapel Hill with that with a planned MRCP, but she hadn't had that performed yet. So on presentation to our ED, she was ill appearing, lethargic, she was in respiratory distress, she was very tachycardic to 126, normal sinus. She was afebrile, but had an elevated temperature of 100.1 with reported subjective fevers. She had increased work of breathing, and on top of that, she was actually hypoxic, 85 to 90%. They placed her on oxygen support with nasal cannula, but she also had audible congestion as well when she presented. She also had a white count that was very minimal, was 10.9, but she did have a lactic of 4.4. They did a chest X-ray for her, which was unremarkable, interestingly. She also had a negative CT, but they had multiple pulmonary nodules, possibly septic emboli based off the radiology read. She had a right upper quadrant, showed her cholecystitis that we saw, but she didn't have any cholecystitis. And her blood cultures ended up being that they drew at that time positive for strep mitis. So they started her on cefazolin, and then ID was also followed for her. So they did a transthoracic echo for her, which showed a normal valve with mild regurgitation of her mitral valve. Leaflets were partially thickened, and then she had some Chordae tendineae, something systolic motion kind of abnormal on the TTE, but they really couldn't specifically identify what it was because it was more of a limited study. So they actually ended up doing a TEE, a transesophageal echo for her, and they actually found very evidently a mobile echo density attached to the Chordae tendineae of the mitral valve that they had suspected on the transthoracic for her, which was very likely to be a vegetation, but their only hesitance was that this was a normal sort of location for a vegetation compared to it being on the actual valve itself or any other foreign implants, which she did not have. So with that, they couldn't rule it out. They continued her on the antibiotics, and then she also had just a line that had a clot on it as well, so they removed and replaced that for her. They did a repeat echo 1 week later after they had her on the antibiotics, and they also found another vegetation as well on the mitral valve itself. So she now had some on the Chordae tendineae and then the valve itself. So the imaging that you see at the top of the slide, it was much more evident on an actual echo that was moving, but you can kind of see on the left, which is the better picture, that tendineae there, and then it's very thickened, very prominent. And you can see how far it extends on the right down. So that thickened portion was the actual area they were concerned had the vegetation itself and what they saw. And that was from the TEE. So for her further management, she continued to do her antibiotics, completed a full course until her cultures were cleared, and ID was following for that course as well. She also had a complicated course, which made her stay in the hospital a little bit longer. She had a Klebsiella infection from her PICC line, and then she had Acinetobacter and Candida for that. So she also had Unicin and Mycofungin to treat those two as well, which she cleared prior to discharging. So overall, infectious endocarditis is increasingly prevalent disease, especially amongst IV drug users. Gram-positive bacteria is the majority cause for the infectious, and TEEs, though, might show vegetation. It is required that you do a TEE, such as our patient, to see any sort of questionable areas or areas that might be missed that you would catch more on a TEE, because that does lengthen your antibiotic course and that would change treatment. And then though the valve leaflets and foreign implantations are more likely to develop vegetations, it is not impossible to see it also on the chordae tendineae or any other areas, as you see in our case as well. So opening up to any questions.
All righty, thank you very much.